Well, hello everyone. This is Chris Fergno. We are going to be talking about the anterior and medial thigh today. So hopefully you will have already watched the posterior thigh, the gluteal region, and the hip joint before looking at this. So let's begin. So please take a moment to look over the learning objectives. And let's begin with the osteology as it pertains to the anterior and medial thigh. So once again, as a review, we have this pelvis. We're going to be focusing on the anterior pelvis more today, and of course the thigh and the leg and the ankle and foot. And we're going to see obviously this musculature in this area and then in the medial area as well. So the next few slides are a review over what we went over last time. So again, as a review, we have the iliac crest. We have the anterior superior iliac spine, or ASIS. We have an AIIS, or inferior iliac spine. And on the outside, we have this gluteal surface. But on the inside, we're going to label this in a different color. We're going to call this the iliac fossa. So that'll be important for a muscle we'll see coming off of that. We also see the acetabulum, or the socket of the ball and socket joint. All right, continuing on, here we have this pectineal line, which may be maybe a little TMI, if you will. We do see some muscles coming off of that, but we can consider this basically the pubic bone. Okay, sorry, I drew that line a little too far. We'll call that the pubic bone. And of course, we have the inferior and superior pubic ramus. Okay, let me get a new color. So here's that superior pubic ramus, here's that inferior pubic ramus, and that inferior pubic ramus is joining up with the ramus of the ischium, roughly in that area. And as you can see, we have the body of the ischium connecting in with that ramus. Okay, all this forms this obturator foramen. And if you recall, that obturator foramen has an obturator membrane, and it has a little opening. Okay, and that opening allows for the passage, the obturator canal allows for the passage of the obturator artery and obturator nerve. Okay, so let's just draw that in real quick. So we're going to see the obturator nerve. There's the nerve going in, and then we'll draw a little red artery going through there to go into the medial compartment of the leg. Okay, of importance today on this slide will be the lesser trochanter. Okay, so here's that lesser trochanter right here. And we're going to see the insertion of a muscle, that a hip flexor called the iliopsoas, that's going to progress down and insert onto that lesser trochanter to help flex the hip. So here we see that little projection of the lesser trochanter down in that radiograph. Moving on to the distal femur and proximal tibia, we're going to see the quadriceps muscles coming down and inserting into the patella, and then sending a tendon off into the tibial tuberosity here. Has a pretty broad insertion onto that point. And then on the medial compartment, we're going to have muscles that come in onto the femur here, and even more superior to this spot, and then onto this adductor tubercle as well. So let's take a minute to talk about the knee ligaments, and we're just going to highlight these very briefly. We have the medial collateral ligament, also called the tibial collateral ligament, and we have the fibular collateral ligament, or the lateral collateral ligament, that
spans from the tibia to the femur. So we're looking down on that tibia right now. We're looking onto the tibial plateau. So this would be the tibial tuberosity there. And so we see these two collateral ligaments, and obviously they're going to resist stresses in the frontal plane. And then we have two other ligaments, the notorious anterior cruciate ligament and its partner, the posterior cruciate ligament. And they are going to resist movement more in the frontal plane, but if we look to see that they are oblique, if we look on this picture on the right, that they're oblique and they cross one another, thus they're named the cruciate ligaments, which means cross. They're also going to resist rotational movements. So it resists movements in the sagittal plane, but also rotational movements. On this picture on the right, we can also see these collateral ligaments coming down, with the lateral collateral ligament attaching the femur to the fibula, thus the fibular collateral ligament. And then we also see the tibial collateral ligament attaching the femur to the tibia. Let's also take a look at the menisci. So we have drawn here in yellow, we're going to draw in the borders of the menisci. So they're these C-shaped structures, and they are going to help give the knee more congruency. In other words, that the femur and the tibia, there's going to be more contact area between the two because of these menisci. Also, it's going to give a little bit of cushioning. So obviously there is some cartilage on the bony surfaces. Here we see cartilage on the femur, and then to the left picture on the left, we see some cartilage here and here. But now we put some fibrocartilaginous discs in here, and those are the menisci that help give it a little bit more cushioning. Now note here that the menisci, note the blood supply for the menisci, that the lateral margin gets quite a bit of blood, or the outside margin, but the inside margin does not. And therefore, if you tear your menisci in the inside portion, it doesn't heal very well. But if you were to tear it on the outside portion, it heals much better. Also note here that we have a patella, and we can see that here. And that patella has a little ridge, and that ridge corresponds to a groove in the femur. So that patella generally should track very well, but as we'll see, there might be some abnormal pull on the patella by the muscles, and then therefore we get some problems, most likely something called patellofemoral dysfunction. And we'll talk more about that in a little bit. And here we see that ridge riding in this groove.
So let's do a little overview of the thigh. So we're going to be talking about the generalities of the thigh, as well as the muscles that are entering the thigh from the pelvis. So here we see a cross section that we saw earlier, and if you recall, up is anterior, down is posterior. This is a right leg, so this would be that's an M. This is medial here. Okay, so we have this anterior compartment. So you see the anterior compartment is quite large and bulky, and we are going to have quite a bit of muscle in this area. And separating these compartments, as you recall, are these intermuscular septa that come in. So this is a nice slide because it's a nice overview of these compartments, and it gives you some of the vital information, such as in the anterior compartment, the primary nerve is that femoral nerve. The primary artery is the femoral artery. Now in the medial compartment, the primary nerve is the obturator nerve and the obturator artery, and then the femoral likes to kind of help out and dish out some blood as well to the medial compartment. So we're going to say this likes to help. Okay. Again, please don't freak out when you see this. Once again, you do not need to know this entire slide. This is just to try to help you to see where some of these nerves are going to be coming from. So here we have the femoral nerve, and if we trace this back, we can trace it back to L4, L3, and L2. Okay, and same for the obturator nerve. Boom, boom, and boom. So we have L2, L3, L4 for both the femoral and for the obturator nerve. Do you remember where that sciatic nerve came from? Any recall of that? Well, here's L4 and here's L5 forming this sucker called the lumbosacral trunk. And so this is going to help contribute to that sciatic nerve, but you'll also get S1, S2, and S3 coming down as well to help form that sciatic nerve, which is going to contribute to, as a review, here's your sciatic nerve, cross section of it, and if you recall, it's going to be two nerves in one. Laterally, we're going to have the common fibular nerve, and medially, we're going to have the tibial nerve. And I'm not sure if this really adds anything. Maybe it might confuse more than anything else. I left it in here really because this does kind of summarize all three of the nerves. But from an inspection of this picture, it's kind of hard to make out where things are coming from. But at least you can see here L4, L5, S1, S2, and S3 contributing to that sciatic nerve going down the back of the leg. And maybe with a little extra imagination, you might be able to make out L2, L3, L4 coming down to help form the femoral nerve that's going to pass through anteriorly. And then you can also trace back this obturator. Maybe I'll change the color. This obturator nerve coming back similarly to L2, L3, and L4. So if you recall, up in the arm and in the forearm, there was some dense fascia covering the outside of the arm and the forearm, especially the forearm and especially in the extensor compartment. Well, in the leg, there's very similar, except the except the fascia is named, and in the thigh, there is the fascia lata, and in the leg, we have the crural fascia. So that's the leg. So this is just another view of those intermuscular septa. Up here in the thigh, we have three of them. Three intermuscular septa helping to form three compartments of the thigh, along with the femur helping to separate those compartments. Okay, so let's take a minute to talk about the major blood supply for the leg in general, or for the thigh, I should say, in general. So here we have the aorta up here. So as you might imagine, that we have a heart way up above pumping blood out and sending blood down the aorta through the thorax into the abdomen, and here we see it in the pelvis. And we have the common iliac separating off, and I want you to know this, that there is a common iliac that is going to come down, and then that's going to break up into an external iliac and a smaller internal, but very important for the pelvis, an internal iliac. And this external iliac is going to cross the inguinal ligament. Here's the inguinal ligament. And once it crosses that inguinal ligament, it then becomes the femoral artery. So here is the femoral artery. And it's very large and it's very vulnerable. It's very superficial. And you can feel a pulse in this area if you go halfway between your ASIS and your pubic tubercle over here. You go about halfway and you palpate. You should be able to feel a pulse in this area. You have to press mildly to moderately in this area. Sometimes you have to back off the pressure a little bit and you might feel that pulse. So this is where blood is flowing down, and this is really the large blood supply for the leg. Now, of course, you know, based on a previous slide, that we also have this obturator artery. And the obturator artery is coming out of that obturator foramen through specifically a little obturator canal. And it comes off of the internal iliac artery. So here's that blood. It's flowing into the internal iliac, and there's a whole bunch of branches off of that internal iliac. And it continues down as the obturator artery into this medial thigh. So let's go back to the femoral artery. And we have this femoral artery. I'm now going to change my color to, let's go to kind of a yellow. So we have blood in this femoral artery, and it can continue down anteriorly in the thigh and help to serve the thigh, either medial or laterally, in the anterior compartment. Of course, some of that's going to get through to the medial compartment as well. But switch my color to light blue. As some of the blood comes down, it's going to take off this way into a deep femoral artery. Just like we had a deep brachial, we have a deep femoral. And it's going to continue down. Now, it does continue down in the anterior compartment of the thigh. However, it's going to give off little branches that end up going to the posterior compartment. I drew more than there are. I think there's about 4 or 5 of them, but you get the idea there. I know that's kind of a bloody mess of illustration there. I apologize. So this is the venous return for the lower limb. And if you recall in the hand, we had a dorsal venous arch. So in the foot, we have a dorsal venous arch as well. So here's that dorsal venous arch. And the great saphenous vein originates from the medial side of this arch, extends anterior to the medial malleolus, which is there, anterior, extends up through the anterior leg. And then just before you reach the knee, it kind of curls around to the back and runs posteriorly into the medial side of the popliteal fossa. And it continues up back anteriorly to dump into the femoral vein. So it crosses through this fascia lata, an opening in the fascia lata here called the saphenous ring. And then it goes into that femoral vein, which ends up going up through the common iliac vein and then up into the inferior vena cava. On the lateral side, change my color here to orange. On the lateral side, we have the small saphenous vein originating going posterior to the lateral malleolus up the back of the leg. And then at the popliteal fossa, it turns into the popliteal vein here. And then it turns into the femoral vein after the popliteal fossa. So where the pelvic cavity, here's the pelvic cavity, meets the leg, we have to have a transition zone. Obviously, we have the pelvic contents. We have organs, viscera, within the pelvis. So we have all this viscera up in here. Viscera meaning organs. Again, this might be a uterus. This might be some of the GI tract, so some of the small bowel or the large bowel. This could be obviously a little higher. We'd have kidneys and other structures. So that's all resting up above here. Okay, and we need to have some separation between it and the leg. So the separation anteriorly between the ASIS and the pubic tubercle is this inguinal ligament. And so this whole area is called the inguinal space. So where is the actual inguinal space? We have this inguinal space here. And again, this is a transition zone between the pelvis and the leg. So this is a bit of a cross section, but not quite a perfect cross section. Again, we're going to label this as I'm going to put leg. Maybe I'll change this to thigh. Here's your thigh, and this is your pelvis. And again, we just saw a femoral vein that's coming up from the leg. It's going to be coming up here, and once it goes past this inguinal ligament or through this inguinal space, it becomes the external iliac vein. In the opposite direction, we have blood coming down through the external iliac artery this way, and at the as it comes past this inguinal ligament, it then becomes the femoral artery. Right? Here we have a femoral nerve that's coming out from the pelvis from L2 through L4. That's coming past the inguinal ligament, and now it's entering the leg to innervate a whole bunch of muscles in the leg. And those are the three main structures. So we have, this is give this a label of a V. I can't see that very well. It shows the same color. A V. This is an artery. We'll call this the A. This is the nerve. Okay, so it's van, at least for the right leg, it's van spelled backwards. Right, to help you remember from lateral to medial, obviously NAV, this is an empty space. We'll call that the E. And then over here are lymphatics. So we call that L. So we have navel, again, from lateral to medial. So clear the screen. Now we can also view some muscles coming through here. So here we have a big old muscle. Call this the iliacus. You can see it just there a little bit. ILIACUS, iliacus. And then over here, we have another muscle you don't need to know about. But then you can see the little break here, right up in there. So this is the psoas muscle. And you can see that there, PSOAS. So we have the iliacus, and then we have the psoas, starting with a P. Now, how does that iliacus and psoas get down into the limb? So here we have the psoas muscle. It's a beautiful muscle. We'll see this in the pelvis at some point. And we can see that it originates from the vertebral bodies of T12 sometimes through L4. So T12 through L4. So again, it comes from the vertebral bodies of the lumbar spine. It probably can act at the lumbar spine. So you want to keep that in mind as you're examining this muscle, because we're going to call this muscle a hip flexor, because as you can see here, it's inserting on the lesser trochanter of the femur. So it's going to be able to move this femur. But imagine this femur was fixed. You could actually help to move the lumbar spine through using your psoas major muscle. Also extending down into the thigh is the iliacus muscle. We see the iliacus here. So this iliacus has this very broad origin, something like that, from the iliac fossa. Okay, that's called the iliac fossa. And of course, this muscle is now extending down past that inguinal ligament. So you can see that inguinal ligament right here. Here's that inguinal ligament. And both of these muscles are extending down, passing underneath that ligament to insert again onto the lesser trochanter of the femur. The contraction of them is going to pull upward, and therefore it'll produce hip flexion. So these are very powerful hip flexors. Okay, so let's actually get into that anterior compartment now. We've talked about the transition from the pelvis into the anterior compartment. So let's actually delve into that. So you might be wondering, are either of these my legs? No, neither of these are my legs. My leg would kind of look like that. Okay, there's my thigh right there on that individual. All right. Okay, this is another nice overview slide of what we're going to be dealing with the anterior compartment. So we have all of these muscles. So let's just give a bracket here to the quad muscles. Okay, so that's the quad. Those are 4 muscles. Plus we have the sartorius, and then we just saw that iliacus and psoas muscle coming together to form a single muscle called iliopsoas. So how do we deal with that in the gross lab? Well, if we're in the pelvis, we call it iliacus or the psoas muscle. If we're in the leg, we call it the iliopsoas. I'm sorry, if we're in the thigh, we call it the iliopsoas. And here we have the major blood supply, of course, and the major nerve as the femoral artery and the femoral nerve. So the first muscle we get to, the most superficial one, is the iliopsoas. I'm sorry, is the sartorius muscle. So the sartorius is pretty cool. It comes from the ASIS and inserts down here onto the anteromedial tibia, a little bit below this condyle right here. And this is called either pes anserinus. So what is pes anserinus? Well, it's oops, no, that's right. It's Latin for goose foot, okay, because there are these little striations in it, and it kind of looks like a goose's foot. So that's kind of neat. We've already seen one muscle from the posterior compartment that inserts onto the pes anserinus. I didn't mention it as such, but we have the semitendinosus on the medial side. And then we're also going to see this muscle right here insert onto the pes anserinus as it extends on the far medial side, or the inside of the thigh, as it comes down as well. That's called the gracilis, by the way. Okay. So the sartorius gets its name because this muscle was quite large in a subset of individuals, those who were tailors, and so the word for tailor is sartorial. And so you can see this position of a tailor where their hip is flexed, it's externally it's flexed, it's externally rotated, and it's abducted. So that's exactly what the sartorius does for these individuals. It brings the leg up, it brings the leg out, and it turns the leg out. So that's what this does. It flexes, it abducts, and it externally rotates. And it is innervated by the femoral nerve. By the way, it's also the longest muscle in the body. Okay, so after the iliopsoas complex and the sartorius, the only muscles left are the quadriceps. So obviously quads mean 4. The only muscle to cross both the hip and the knee joints is the rectus femoris. So here we see the origin of rectus femoris. Okay, that's coming off the AIIS. Okay, and it's extending down, so it's crossed the hip there. It's extending down into the common extensor tendon, or the quad tendon. And then we have a patella that's enveloped in this quad tendon. And then beyond that quad tendon is the patellar ligament, which a ligament attaches bone to bone. So we'll call that a patellar ligament. A lot of times people will call that patellar tendon, but that's technically not correct. This is the tendon, and that's the ligament. So put a T here and an L here. Okay, and then on the medial side, medial to the rectus femoris, we have
the vastus medialis. You can see that the fibers kind of run obliquely. We'll see that in lab. And vastus lateralis, where the fibers run obliquely as well. So that's 3 muscles, and we need 4. So we're going to remove this rectus femoris. We'll jump over here. Okay, if we remove that rectus femoris, we see the vastus lateralis underneath it. And so there's your 4 muscles. So what are these guys going to do? Well, when they contract, they're going to pull upward. They're going to pull upward. Okay, so that will extend the tibia. Extend the tibia at the knee. And all these are innervated by the femoral nerve. So here's an illustrative view of that patellar tendon and the patellar ligament. So we're going to cross this out and we're going to put an L there. Okay, so we'll call that the patellar ligament because we're connecting bone to bone. Okay. Now, this patellar ligament serves us very well. It's not ruptured very often, but we can really aggravate the heck out of this thing, especially if you take up a new sport that includes a lot of jumping. So we call this jumper's knee. If you take up, let's say you were to take a camp, a volleyball camp during the summer as a high school student, you might end up developing some really painful irritation in this area, and that's called jumper's knee. So while we're here at the patellar ligament, as you can see, the proximal part of the tendon is most affected by patellar tendinitis. If we have an issue more distally here and possibly right over the bone, we have a condition called Osgood-Schlatter's disease. Osgood-Schlatter. My German's not very good, so bear with me here. Osgood-Schlatter disease. So this is extremely common in young athletes, especially adolescent athletes who are undergoing a growth spurt and who are involved in activities such as repeated jumping or anything else that puts a lot of tension on this patellar ligament, like jumping. Or it's common in high school catchers as well, baseball catchers who go into that deep knee flexion and have this constant pull of the patellar ligament. So the last clinical correlate I want to give for the anterior compartment is something called patellofemoral dysfunction. This is extremely common in younger athletes, especially those, again, going through a growth spurt, and especially in the female population, where as their pelvis kind of starts to grow a little wider out this way, the angulation of their leg goes from a quite vertical leg to something a little bit more oblique. And the line of pull of their muscles is a little off. And so you can imagine that as the leg rotates out that way a little bit because of this change in the pitch of their pelvis, that the pull of the patella in this direction might actually go a little bit more this way because of that change in orientation. Or you might have something like excessive pull from these lateral structures, okay, that pull further laterally and less pull from the medial structures, and therefore we get some tracking issues. So we would call this a tracking issue of the patella on the femur. So let's shift over to the medial side. So now we're going to go this way, and we're going to cover the medial compartment of the leg, which is in this direction. And this is colloquially known as the groin. So within this cross-sectional view, we're going to be heading into this direction. Now note that the medial compartment has several muscles. Now, as you can tell here, 3 of them have the word adductor in it. We're not going to talk about obturator externus. We've mentioned gracilis already. Gracilis is that muscle that inserts into the pes anserinus along with the semitendinosus and the sartorius. And then the pectineus is very high up, or is the most superior of these muscles. So longus meaning a long muscle, brevis meaning a short muscle, and magnus meaning a very large muscle. And these are innervated by the obturator nerve, and the primary blood supply is through that obturator artery along with that femoral artery. So here we have a view of the obturator nerve and a bit of an overview of the entire musculature of the medial compartment. So what do we see here? We have this obturator externus that I said we wouldn't really talk about. This is the only view we'll get, and we will not see this in the lab. It's going to be obscured by a lot of other stuff, such as a iliacus, such as a psoas muscle coming down, and you won't really see very much of that obturator externus. What do we do have? We have the pectineus very high, and then just inferior to that we have brevis, and then just inferior to that we have longus. Now, those are what we're going to see as we look into the medial compartment, and then deep to it we have the adductor magnus that I'm outlining here. So it's the most posterior muscle, and that's a little opening for the vasculature. So it extends all the way down here. So it is quite large. So let's look at that nerve. So here we see the nerve. I'll color it in blue. So here we see that nerve coming down from L2, 3, and 4, extending down, passing underneath the superior pubic ramus. Here's that superior pubic ramus. It's coursing underneath that, and remember there'll be a obturator foramen. It's going to come out of the obturator foramen. It's going to split, and it's going to innervate this entire muscle compartment. And then, don't forget the cutaneous innervation. You're going to have some sensory up in this area. So this medial thigh will be served by the cutaneous branch. So if you were to have a lesion of L2, 3, or 4, you might have a decreased sensation in that area. So here we can see the muscles a little bit better, actually the individual ones. And so we can see all of these muscles coming from mostly the superior pubic ramus. If not the superior pubic ramus, then the body of the pubis, kind of the more medial edge of the pubis. So superiorly we can see this pectineus muscle, and we'll see this in the lab quite well. And then we'll also see the adductor longus muscle very well. Now, if you peek in between the two, so if you open up this edge and this edge and kind of fillet those open a little bit more, then we'll get a chance to see this adductor brevis muscle sitting a little deep to the pectineus and adductor longus. But from superior to inferior, we would see first the pectineus, and then the brevis, and then the longus. So from superior to inferior, it's PBL. Okay. And then, of course, here we see it most medially, again, coming off this far medial edge of the pubic bone. We have the gracilis extending down and inserting all the way down onto the tibia. So, which medial compartment muscle can act at the knee? That would be gracilis, can act at the knee. Directly, anyways. Can the brevis? Nope. Can the longus? Nope. Can the pectineus? Nope. And then we'll see that the magnus is also unable to. And we'll see the magnus over this side in the dark gray, but we'll see that more in a second. So one more thing to add, that the pectineus is innervated by the femoral nerve. Okay. and then all the others are innervated by the obturator nerve. And then, of course, Magnus is as well. So here we see that adductor magnus in all its glory. And note that, yes, the adductor magnus is large. It comes off the pubic bone. It also comes off the ischial bone. So it comes off this, has a very large, broad attachment point over here. And of course, it has a very large, broad attachment here as well, all the way down to the adductor tubercle, which is what this is, the adductor tubercle here on the distal medial femur. There is a break in this adductor magnus, so you can imagine that on this left leg we have the femoral artery extending down anteriorly, intermedially, and then it's got to get behind the knee. So it's going to shoot through this hiatus. I hope you're watching. Going to go through that hiatus, and it's going to end posterior to the knee. And of course, we'll also have a popliteal vein. I'll color that in light blue. So the popliteal vein is coming up posteriorly and is going to shoot through that adductor hiatus to travel with the femoral artery up that in that direction. Good. And this essentially says the same thing. So this slide is really focusing on this area where we have a canal, which is essentially just some bordered muscles. You do not need to know the adductor canal, but it is nice to know so you can appreciate the full picture of how these things are traveling, that the adductor hiatus is where these vessels, especially the popliteal vein and artery and the femoral vein and artery, are traveling. And the adductor hiatus is the transition point for those names. So it's the transition of the femoral artery becoming the popliteal artery and the popliteal vein becoming the femoral vein. So that's the transition point. Okay, well, let's take a closer look at the femoral nerve. So we mentioned before that the femoral nerve often innervates the pectineus. So here we have the femoral nerve, and it's climbing out from underneath the lateral margin of the psoas muscle. So we'll see that in the pelvis. We get this femoral nerve as it's traveling down beneath the inguinal ligament. And essentially, it splays out at this point. Here, the artist is showing it splaying out down here, but it often can splay out at the inguinal ligament, and it's going to splay out in a whole bunch of branches. So it's basically going to have a whole bunch of nerve branches. And then a single solid nerve is going to continue on, and that nerve is called the saphenous nerve. So if you recall, we had a saphenous vein, or a great saphenous vein. Well, now we have the saphenous nerve that's traveling down. Again, it is a large branch or a continuation of the femoral nerve down towards the medial leg, and this is going to be responsible for giving off cutaneous innervation to the leg, and it's going to do that by penetrating the deep fascia, and it's going to supply the skin in the front of the knee, in the front of the thigh, and also down on this medial leg. It's going to give off a important nerve. This way you don't need to know the name of that nerve, but this nerve is often cut with knee surgeries. So as that surgeon comes in and makes a slice right there, it's going to create a numb spot on that area right there. And I've had a couple ACL surgeries, so I have numbness on that side because of my branch of my saphenous nerve called the infrapatellar nerve that's been sliced. So here we can see the distribution of that saphenous nerve. So I'll just kind of do a general outline. Okay, so we have this anterior medial leg, and the posterior medial leg is that saphenous nerve brought down by L4, and that corresponds to the most of the L4 dermatome. So the inferior medial margins of the knee are generally L4, as is the anterior medial leg is L4. The anterolateral leg is generally L5. And then this is a nice key spot for L3 is the anterior medial thigh, and then the interlateral, more proximal segment of the thigh. So I like this for testing L2. Here for L3, we tend to test this general area for L4 and this general area for L5, but we also, just like C6 was our thumb, L4 is the great toe, L5 is the second or third toe, and then S1 is the pinky one. So if you remember, this would have been the equivalent in the hand of C6, C7, and C8. Well, I'm going to cross those out so you don't get confused. But L4 for the great toe, L5 for the second or middle toe, and S1 for the pinky toe. Even more important would be the cutaneous innervation for the sole of the foot. As we are interacting with the ground that we walk on, we obviously step on little structures here and there. Generally speaking, L4 is the medial foot, and as you go laterally, we get into S1 over here with L5 somewhere in between. That's the general rule of thumb, and we'll talk more about that next time. The next two slides are a table of all the muscles and the pertinent information. They're simply for your use. Please take a look at them. If you happen to notice any mistakes, please let me know. But otherwise, that concludes this lecture. Next time we will be talking about the leg, both the anterior and posterior compartments of the leg, and a little bit about the foot. And then afterwards, we'll be moving on to the trunk musculature, and also the viscera of the thorax and abdomen, and a little bit of the pelvis. Until next week.